Cyclothymia is a milder form of bipolar disorder. If you have been experiencing a steady cycling of mild mood changes for 2 years or more, you may have a lesser form of bipolar disorder known as cyclothymia or cyclothymic disorder. Both cyclothymia and bipolar disorder are characterized by extreme mood swings from the highs of mania to the lows of depression, with short periods of neutral time in between. The difference lies in the intensity people with bipolar disorder. The difference lies in the intensity people with bipolar disorder will experience major depression and clinically diagnosed mania, while patients with cyclothymia will experience low-grade depression and mild mania, also known as hypomania. With cyclothymia, it may seem like you are just going through a string of good days and a string of bad days, says psychiatrist Kathleen Franco, MD of the Cleveland Clinic Lerner College of Medicine in Ohio. But the mood shifts keep going and there is little neutral time in between. Besides cycling between the two mood extremes, the other criteria that will help determine a diagnosis of cyclothymia, Besides cycling between the two mood extremes, the other criteria that will help determine a diagnosis of cyclothymia include: you have experiences these mood swings for at least 2 years. Your symptom-free intervals last no more than 3 months. Your symptoms do not meet the requirements of any other bipolar disorder.
The issue of terminology in bipolar disorder is very important for the family who go to read in books of psychiatry, for the psychiatrist himself who will to select the specific terminology to explain to the family about that psychiatric disorder. We have the term bipolar disorder. Bipolar, when translated to Arabic, they have a different meaning of that presentation to some extent, because when translated to Arabic mean the people think about something different than the symptomatology of that disorder. Affective disorder is more, I think, in my belief, is more appropriate to be used in the description of that disorder. Affective disorder, it's related to the affect, and the affect is so respected by the society. Then using this terminology of affective disorder is very important and more appropriate to be used. A lot of terminology in that issue. When you go to and read yourself, as a father or mother, brother, sister for that patient, please don't be bothered with this terminology. Look for the symptomatology and the way of the management and the role of the family in that management. If you go and you are so panicky about this terminology, it may affect you. This terminology has been used to teach psychiatry for the students, to teach psychiatry for the postgraduate psychiatrists, and the way of communication between researchers in psychiatry.
Manic episode, it may continue from 1 month to 3 months. And there is level of manic episodes, mild or hypomanic or slight manic episode, like slight degree of happiness without any previous reason. Another thing that you can find, that the episode started that the patient feel nervous and anxious and he cannot control his temperature. Another thing that you can find in the manic episode, that the patient has very fluency of speaking. He can give him his opinion in any subject, even if he has no information or knowledge about this subject before. Another thing, you can find also the patient with distraction and want to make a lot of tasks at the same time. Another thing, you can find also the patient cannot control himself and his impulsivity. And this episode started to be at the adolescent phase, especially late adolescent phase after 16 years old, and then it may continue till the late adulthood, till 45 and 50 years old maybe.
The manic episode presentation not always in the classic and traditional way of mania, which is high affect, which is so expansive, so elated mood. No. The manic episode either to present in one of three modalities. One of them is the elated mood, is the high mood, the euphoric one. The other one, no, is the expansive mood. The third one is the irritable mood. Sometimes the mood comes so irritable that we could mix the mania with anxiety. And that one with expansive mood, sometimes we think this is a normal person, but he's a little bit high or talkative more than the usual. And the classic one is the elated mood. And for the family, when they notice any change in the behavior, in the way of thinking, in the mood, in any different way, they should consult their psychiatrist, either by phone or visit or whatever the presentation. Sometimes the manic episode come and colored by the personality of the patient. For example, if the patient is an anxious person, then he has a mania. This mania come with colored with the anxiety symptoms. He will be so meticulous with manic symptoms. If the patient is so, for example, avoidant personality, which coming with poor self-confidence, and he present with hypomania, he enjoy that hypomania because he want to get rid of that avoidant personality or the low self-confidence he is having and suffering from most of the time.
Hypomanic episode don't disturb functional and occupational of the sick patients. Patient or person with features of hypomanic don't disturb him or her in life or his life.
Usually there are certain clinical features that might help us diagnose the bipolar in addition to the clear diagnostic criteria which is posed by the DSM-5. As we mentioned, one of the most and clear clinical feature is the disturbance in mood. Patient used to be having an euthymic mood, which is like a regular mood like any other individual, suddenly becomes elated, inflated mood, so happy, laughing inappropriately, inflated self-esteem, believes that he has a sense of empower or of great wealth. Some of them actually might go into a psychotic episode in which they believe that they are, for example, something bigger than what they truly are. They might believe that they are kings or princes and sometimes even prophets sent by God, and they hold these delusions very strongly. So these one of the clinical features that help us aid. Another one is the decreased need for sleep and hyperactivity. The patient or the family might complain that the patient is awake all night long, hyperactive, roaming around the house, doing certain, as we mentioned, pleasurable activities, smoking. Sometimes they go out of the house, they want to drive long distances, they might want to travel, and they spend their money in buying stuff, in traveling. They might even give money away to certain individuals.
On the construct completely, on the manic episode, you can find that the patient who's suffering from major depressive episodes has sadness, helplessness, feeling of hopelessness, feeling of lack of activities, lack of interesting, social withdrawal and social introversion, started to hate himself, some of the patients started to accuse themselves and say internal his mind that I am the main responsible in every negative thing that happens to me in the life. Some of the patients started to have a lot of death wishes, started to ask the God, why God you give me the life till this point. Another patient started to make a suicidal plan, as I explained it before. Another patient started, by the way, in the reality, the depression can be diagnosed in the children and also in geriatric. And another patient who suffering from major depressive episode started to think that there is no useful to this life, and even patient started to neglect themselves and their self-hygiene and even their eating. A lot of patients may lose the ability to eat and lose the appetite to eat and started to weight loss in a severe way. Another patient started to enhance the mood by overeating the sweets and high carbohydrates and high calories, and this is induce obesity, and obesity induce distortion in body image, and distortion in body image induce depression episode.
Hypomanic episode and manic episode and depressive episode or major depressive disorder, collective of them to induce bipolar disorder. Hypomanic episode is a disorder characterized by elevated or expansive or irritable mood and increased energy of activity and associated with increased self-esteem and distractibility and increase or to decrease to need sleep, walking at morning, talkative and pressure in speech. This criteria met for diagnosis of hypomanic episode.
Bipolar disorder is more common in high income than in low income countries. About 0 to 7% of patients who are suffering from bipolar disorders may presented high level and presented high economic level. Another important thing that if you make a preview in the family history of patients who are suffering from bipolar disorder, you can find that most of them with separated family, separated parent, divorced mother, so that the individuals who are suffering from bipolar disorder, whether type 1 or even type 2, may present poor dynamic interactive relationship.
Now, if you spoke about the bipolar affective disorder, we find that there is a clear diagnostic criteria for it found in certain manuals, like for example the DSM-5 or the ICD-10, which are manuals used by mental health professionals and institutes to categorize and give a diagnostic criteria to individuals. So to diagnose a bipolar affective disorder, the criteria propose that the patient should at least have one manic episode. So having one manic episode is enough to diagnose a bipolar affective disorder. Whether or not he has a depressive episode is not included in the diagnostic criteria. However, most individuals later on might go on and develop a depressive episode. So as we mentioned, one manic episode is enough to diagnose a bipolar disorder.
The first episode of bipolar disorder could be a hypomanic, manic, mixed or depressive episode, and the prevalence is estimated to be 1.5%, and the condition is commonly equal in males and females. Probably bipolar 2 are more prevalent in females.
We can find that there is associated features which can help to support the diagnosis of bipolar disorder, that there is this insight of illness and disease. Patient with bipolar disorder not perceived that he is sick or ill or suffering from some sort of mood disorder. Another thing, we can find that the patient has disinhibited behavior or sexual tendency. Another important thing, that his speech is very, very, very distractible and cannot make a good conversation. You can find the patient easily distracted by other stimulus around him in bipolar disorders.
Bipolar 1 is defined as one or more manic episode or mixed episode with or without the history of one or more depressive episode. Bipolar 2 is defined as one or more depressive episode with one or more hypomanic episode.
The exact causes of cyclothymia are not known, but it's often a result of the same genetic factors that cause bipolar disorder. In fact, There is an estimated 15% to 50% risk that people with cyclothymia will eventually be diagnosed with bipolar disorder following a full-blown manic episode or major depression. People with cyclothymic disorder usually have a family history of major depression, bipolar disorder, suicide, or alcohol or drug dependence.
Now, if we spoke about the cause of mood disorder, like bipolar affective disorder or cyclothymia, we find that several research has been done and still going to find a clear cause for the mood disorder and for psychiatric disorders in general. If we spoke about the bipolar affect, the mood disorder in particular, we find that there are several theories. One of them is that the genetic component is a role in the cause of the disorder is quite clear. There are several twin studies that found there is a high concordance rate between the twins of developing disorder. Also, the family history is quite clear. Usually, a patient with bipolar disorder has a family history of the same disorder within his family if the history is taken.
We have certain poor prognostic factors as well as good prognostic factors when we speak about bipolar affective disorders. For the poor prognostic factors, psychotic features, being a male, are considered to be poor prognostic factors. For the good prognostic factors, being female or the absence of psychotic features, for example, are considered to be a good prognostic factor in bipolar affective disorder. Bipolar affective disorder causes marked impairment and significant disturbance in the life of patients to prevent them from performing in appropriate way in their daily activities.
The symptoms of a major bipolar depression include dramatic disturbances in sleep, concentration and appetite, debilitating thoughts of worthlessness, low self-esteem, and maybe even thoughts of suicide. Symptoms can long-lasting and dramatically reduce quality of life. The same symptoms may be present in a cyclothymic depression, but they are milder. They may last no more than 2 weeks and they may cause less of disruption in your daily routine. The true mania of bipolar disorder, essentially the opposite of major depression, can likewise be debilitating. It may be accompanied by feelings of euphoria and indestructibility of feeling of I am on the top of the world. That may manifest as dangerous behaviors like driving too fast or abusing drugs or alcohol. The manic person may go a day or two without sleeping. He may talk rapidly, moving from topic to topic without making much sense. The hypomania seen with cyclothymia is less dramatic and not as long-lasting. Your symptoms may be so mild as to seem normal: mild sleeplessness, for example, chattiness and increased energy. Your symptoms may be so mild as to seem normal: mild sleeplessness, for example, or increased energy. Full-blown bipolar disorder. This escalation is especially prevalent if bipolar disorders run in the family. Although preventive treatment hasn't been identified yet, there is some hope among researchers that an early treatment for cyclothymia may one day prevent full-blown bipolar disorder from developing.
You can find the patient in his clinical picture when he presented to you at the clinic or when he started to communicate with family, that he cannot focus and he over-demanding and over-complaining and he over-asking and he over-want to get out and make outdoors activities. A lot also of patients who are suffering from bipolar disorder, whether type 1 or type 2 by the way, may have a disturbance in his feeling by others. He cannot feel that the patient around him started to feel bothering from him or started to feel distress from him.
The very unusual and acute presentation of bipolarity and manic episodes, it may lead the family to go and look for the treatment. But the very insidious presentation of the depressive episode in bipolar disorder, and the patient will be more quiet, make the family will not go and look for the medication or the treatment like in the manic episode. In manic episode, the patient is stressing on the family, but he's feeling okay or more than okay. In depressive episode, the patient usually having the stress on himself, but he's not stressing on the family, except if he have psychotic symptoms, very clear one, with that depressive presentation he is having.
Cyclothymia is defined as persistent instability of mood, mild depression, or mild elation that is not enough to put the diagnosis of bipolar affective disorder or major depressive disorder in account.
If you found a lot of characteristics and a lot of symptoms such as depressive episodes, which is continue from 1 month to 3 months in regular basis, and then you found the mood started to take a different range and different pattern from depressive to manic episode. Manic episode, it means that he feel happiness, interruptive persons during communication and the conversations, started to have a very elevated mood, that he has energy and arousal. He cannot even sleep for 2 days or 84 hours. So that you started to find that his mood from down to high. This is a pattern of bipolar disorder.
Speaking about affective disorders, now we will highlight the diagnostic criteria actually for the manic episode. The first important criteria, there should be a distinct period of abnormal and persistent elevated, irritable or expansive mood. During that period of the disturbance, there should be at least 3 or more of the following criteria or the following features. 4 features should be present if the mood is irritable. The first one, there should be inflated self-esteem. The clients usually have grandiose attitudes. They think they have a highlighted or they have an extra abilities or extra advantages over others usually. There should be also a reduced need for sleep. Usually clients sleep between 3 to 6 hours in general terms. Also clients should be talkative more than usual. Talkativeness is actually a very clear picture of manic clients that we usually meet at our psychiatric clinics. There should be also certain features. For example, there should be a distractibility. Clients usually do not follow our flow of speech. Usually they shift from one topic to another topic. Also, there should be an increase in the goal-directed activities. For example, social activities, work-related activities, and sometimes we may have excessive involvement in certain pleasurable activities. There should be an elevated, expansive or irritable mood. The duration should be at least 7 days, at least 1 week. During such disturbance, there should be 3 or more of the previously mentioned features, and the symptoms do not meet the criteria for any mixed episode. There should also be a significant interference with the client's way of living, and the symptoms is not due to the direct physiological effect of certain substances, and should not be also due to any other general medical condition.
There is no cure for cyclothymia. Medicines usually prescribed for bipolar disorder, such as mood stabilizers, do not always work on cyclothymia. More often, treatment for cyclothymia involves talk therapy with a trusted psychologist who can help patients recognize the triggers that may increase the severity and frequency of their mood swings. For example, mood shifts can be triggered by lack of sleep, alcohol consumption, or traveling through many time zones. Light therapy can also help treat cyclothymia in time. And with the help of a trusted support team, beginning with your diagnosing physician, you can learn to manage your moods and your response to them and live a life less disrupted by cyclothymia. You doctor or mental health provider aims to decrease your risk of bipolar disorder, since cyclothymia carries a high risk of developing into more severe bipolar disorder.
The main important issue of cognitive behavior therapy is to enhance and recorrect negative thoughts with patients who are suffering from bipolar or depressive episodes. How come? You can put the advantage of the patient and the disadvantage of the patient. This is number one. Number two, you can put a relationship between his ability and the chances and opportunities that he takes in his life. Another thing, you can make a time management, as I explained before, to enhance his enjoyable activities and started to make what we call life roles, to start to make a relationship with family members, with friends, with relatives, with colleagues at work or at academic performance. Another thing, you may focus in cognitive behavior therapy to make a relaxation or muscles relaxation, what we call in psychiatry and clinical psychology progressive muscles relaxation. And this is a very treatment who has very improvement in a short-term way to make the patient lying on his back and started to take a whole deep breath from his nose and started to get over this breathing or respiration from his mouth over and over, and then started to take the breath with muscles construction and then get out the breath from his mouth with muscles relief. And this is going to help the patient a lot if he do it in a regular basis for 2 weeks to 3 weeks.